Welcome everyone, and I really appreciate folks joining in for this session. We're going to talk about digitizing surgery, which is a very exciting topic. And if you would go to the next slide, Dr. Joseph. Some of the work we're doing at Johnson & Johnson with our CSATS organization. I'm the head of that organization. My name is Dave Herrmann, so I'm the global head of digital solutions, which is part of the Johnson & Johnson medical devices family of companies. And within this company, we have an organization called CSATS, which is developing a video capture technology platform for improving surgical skills. And we're going to talk to you a little bit about some of the work we're doing there and how that we think can meaningfully change the standard of care in the perioperative environment. And I'm joined by my colleague, Dr. Saju Joseph. And Dr. Joseph, I will hand it over to you to introduce yourself.
So thank you very much, Dave. So I'm Saju Joseph. I'm the Residency Program Director at Valley Health System. I'm also a professor and Vice Chair of Surgery at Touro University. My background is General Surgery Program Director and really drive for using and integrating innovation into surgical education, and within that, driving the capabilities of understanding surgical quality in real time. So kind of a marriage of CSATS into use both in the educational platform setting as well as kind of overlapping it into the quality side.
Awesome. So what we're going to do is just have a brief presentation here, and then we'd like to have a dialogue with Dr. Joseph as well as our audience. But when we think about, the entire patient care continuum, and the things that happen to that patient, the data that are collected around that patient, there's one really significant, missing piece in the whole equation, and that's what happens in the OR and surgery. We feel like this is a bit of a black box of data, following a patient's, care pathway, and we want to create transparency into that black box. And we think about some of the major metrics, that hospitals, track and measure themselves on relative to performance. When you think about length of stay, readmission rates, operating margin, operating time, et cetera, all of these can be meaningfully tied back to what happens in that OR. But today we're not measuring what's happening in that OR. We don't collect data from that environment. So what if we did? Let's go to the next slide. If we did, I think we could meaningfully demonstrate transparency into what's happening. One of the things that, we've noticed in the literature and through our own technology is that, surgery is extremely variable, I think, as we all know. And one of the big variables taking place in that OR is the skill of the surgical team. And in the literature, you see that, depending on the surgical skill as measured by standard kind of technical assessment rubrics, can have a meaningful impact on the outcomes of that procedure. So higher skill surgeons in surgery is associated with fewer complication rates, reduced mortality rates, shorter procedure times, fewer readmissions. In general, just higher clinical outcome quality, lower economic impact of surgery. And so what if we could actually, track surgical skill and give feedback on an ongoing basis to surgical teams? That would have a clear impact, as you can see here, on a lot of these meaningful outcomes. Let's go to the next slide. So what we've done at J&J through our CSATS product is created a technology platform for doing just that. So as you go from left to right here, what CSATS is, it's a device that you put inside an OR that captures the surgical video. So in minimally invasive surgery, as folks certainly are aware, those procedures are done under video assistance, whether it's laparoscopic surgery, whether it's robotic surgery. There's a video that the surgeon is using to get a view of the the intra-abdominal environment to conduct their procedure minimally invasively. Typically, that video is just used to assist the surgeon, but what if we could actually collect that video, send it to the cloud, analyze it, and extract information from it? And that's exactly what we're trying to do with this particular device that we place in the OR. We take the video, we record it, we send it into the cloud, into a high-trust certified HIPAA-compliant environment, and we make it available for machine learning algorithms to analyze it. We make it available for expert surgeons to review it, and we give it back to the surgeon and the surgical team who conducted that case so that they can, gain information about what they did and how they're performing. And so let's Go to the next slide, and I'll give a few examples of what some of that information would look like. So after a surgeon conducts a case, they send their video off. They get access to a personalized case report within a matter of hours. That case report gives them back their video. The video is broken down into the steps of the case, the instrumentation they used. If they would like to, they can get a measure of their technical skill on a gears or goals technical assessment rubric. And so there's all kinds of rich information a surgeon gets in this personalized private case report. If they want to have an expert surgeon review their case and give them feedback, opine, give them qualitative feedback, that's available to them as well. So all of this comes post-operatively as feedback to the surgeon using this product. Let's go to the next slide. They can also get access to a personalized performance dashboard so they can track trends and how they're doing on key metrics such as gears or goals scores, as I mentioned, on operative time, on instrument utilization, all in a web-enabled environment. So this is very accessible, on their PC, on their phone. Pretty much anywhere they go, they can access this information in a personalized manner. If you go to the next slide, what we've also made available through this platform is a very rich video library. You've got over 10,000 videos in this library across a multitude of procedures. They are searchable. There are expert surgeons that have posted their videos. They're highly curated, so you can go to relevant steps. You can learn relevant learnings from these videos. So it's an extremely rich searchable database meant for surgeons to access reference videos across a whole host of procedures. We think it's the largest, richest database of its kind, in fact. If you go to the next slide, something else that we've built into the product is a set of administrator features so that hospital administrators, such as Dr. Joseph here, can gain visibility into what their surgical teams are doing and see how surgical teams are performing relative to one another, how much they're uploading video, how many videos they're submitting for assessments, et cetera, et cetera. So a really rich set of information is now made available as to what is happening inside that OR that we can then use to assess surgical performance, give personalized feedback to surgeons, and of course, as I mentioned, improve outcomes based on that data. Next slide. Something else that you can do and that we're actively working on is how can we train machine learning algorithms to extract information from these videos. And so we're working very actively to analyze videos, to recognize things such as anatomy, case complexity. We're training computers to recognize when it reads a video, what are the steps of the case? What are the activities the surgeon is performing? What are the instruments they're using? We'd like to give surgeons all of this information in the post-operative environment and eventually actually in the intraoperative environment as real-time intelligence. We're also working on procedure-specific insights that we can glean from video analysis. In a lap cholecystectomy, can we help the surgeon recognize when they've achieved the critical view of safety, for example? Can we help them recognize when they have formed proper tissue apposition for an anastomosis? So there's a whole host of additional deep insights and features that we can glean from this video analysis work. Next slide. So what we've been able to demonstrate, CSATS is a product that's been on the market for about 5 years in the United States. A number of large hospital systems are actively using it, and they've been able to realize significantly improved outcomes across key metrics. And you see a few examples of that here. So, reduction in operative time, reduction in blood loss, reduction in conversion to open surgery, lower length of stay, lower cost per case. So these are significant improvements, that we're seeing just by doing routine video capture and video analysis and providing feedback and transparency into what's happening in that OR. So at this point, I'd like to transition and talk to Dr. Joseph a little bit about this type of technology, this type of performance management and quality improvement initiative. If you wouldn't mind maybe hopping over to the next slide, we'll just kind of keep that one up while we're talking. But Dr. Joseph, you, as you mentioned, play a major leadership role in your hospital system as a program director, as a quality leader. What effect have you seen from, adopting technology like this to capture video, measure surgical skill, give feedback to surgeons?
So first off, thanks, Dave, for the slides. I will kind of hit on a couple of questions that have already popped up in the chat in this answer, and I apologize, I'm long-winded. The key to really driving quality when you're talking about intraoperative decision-making, really ultimately what we are looking for from a quality side is identifying the surgeons, how they decide their techniques, and most importantly, how to make them efficient and safe, right? As a program director, my goal is to train surgeons that are safe. That being said, even in every surgical specialty, ultimately what we're really aiming for is understanding how that surgeon is making decisions in real time in the operating room and how those decisions affect outcomes down the road. So this is a type of feedback mechanism that is very valuable. Number one, and I use really simple examples when talking to surgeons because they are simple people. I use the example of NFL players. You know, when they come off the field, the first thing the quarterback does is he grabs his tablet and starts looking at the exact set of plays that occurred just before to see what was done, what did the defense do, and what do they need to modify and change, right? And in real time, this is how surgeons grow and learn. Answering the question about the feedback confidential, it is. Feedback is to that surgeon directly. At least how I have it set up in our hospital system, I can view the administrator log for my residents, but the surgeon of record gets the feedback. We do use it in a peer review side, so for surgeons within our hospital system that have struggles or concerns, we have them start on the simulator, work on the simulator, practice on the simulator, get scores that are sufficient on the simulator, then they go back into the operating room to do those operations, and they use CSATS as their corrective action plan to prove that they are improving their skill set. We, again, back to that chat question, we use it in a lot of specialties, so pediatric surgery, urology, anyone that's using a laparoscope, anyone using a robot can use CSATS. We have even started working on getting the open operative cases recorded. It is not ideal just yet. We actually take a laparoscopic camera, set it on the stand, and record with the laparoscopic camera. We've tried the intraoperative light, except you get a lot of people's heads in the way. So it's really image capture of any sort, and anyone can use it.
Yeah, that's great. Agreed, and I will just echo that, you know, representing CSATS, the technology is available and viable for, you know, any procedure that requires a video, basically, anything done under video assist. And, you know, as Dr. Joseph said, most commonly that's going to be a laparoscopic case or a robotic case, you know, in the thorax, the abdomen, the pelvis. But there are other, you know, video-based procedures as well, and the technology is equally viable there. An additional question, Dr. Joseph, that I thought I would ask of you, you know, you use the analogy that this could be kind of like reviewing game film, like a professional athlete. And this technology hasn't necessarily been available historically for surgeons. It's relatively newly available. A lot of surgeons don't know it's available. How do you get them aware of this type of technology and comfortable with adopting it?
Yeah, so that is probably one of those great challenges. I break, and this is probably true of everybody, but at least in my experience in surgical leadership, we break surgeons up into innovators, early adopters, late adopters, and the complete naysayers. And the early adopters and the innovators are pretty easy. They see it, they understand it. The late adopters are the ones who start very skeptical, but often find that they become the greatest champions. I will actually make the argument that in the future, this will be part of a reimbursement algorithm, right? And when I can show, you know, when you look at doing a preoperative risk assessment as being a viable strategy to increase your reimbursement because you've identified a high-risk patient that you're going to go to the operating room with, the same is true. If I can identify an operation that I did that has scored very well, irrespective of the outcome on the patient or other things, the administration to the insurers becomes very valuable data. And I think that most surgeons who are afraid of it are afraid that they might not score well. And then when you tell them, hey, put a couple videos on, and they see that they're actually scoring right up there with the rest, they become very excited, because it also becomes a community, right? So the slide that you showed where different surgeons give feedback, and I've been on both sides where I give feedback and say, hey, I like the way you're doing this. I'm going to take that and use it in my operating room. And then sometimes I can give feedback of, I like to do a little bit more lateral retraction here or do this there. And that surgeon can pick that technique up and try it in their own operating room. And maybe it works, maybe it doesn't. But the idea is the more surgeons talk amongst themselves and share experiences, the better off they become.
So maybe we'll take a question here from the chat room. I'll go ahead and read the question, Dr. Joseph. Do you see a technology like this being able to help inform clinical best practice guidelines on procedures and operations that may have very different techniques or methods at large rather than at a clinic level?
Yes. So ultimately, and again, this is where your machine learning and the future lays. When you start integrating and overlapping a million tons of data, right, from pre-hospital, the patient that's at home, and we have social determinants of health. We know they haven't been taking their medications. We know their A1C levels are through the roof, and then they show up in the emergency room with, I'll pick the easy acute cholecystitis because we talked to gallbladders, but we know before anything hits that this is a patient with a high risk for surgical complications. All of this data becomes integrated, and CSATS plays a major role in that, right? You know what your surgeon's capabilities are. You know what can and can't be safely done. And so you begin triaging those patients beforehand, and you continuously are improving your operative decision-making, right? Again, back to like my dream world, as that surgeon begins operating and you show those, kind of machine learning lines that you have on your screen, that happens in real life. As the surgeon starts to head towards trouble, he gets a little warning, don't go there. You're in your wrong spot. Head up this way. Or, and that machine is actually learning on the fly. It is watching the anesthesia record. It's watching the blood pressure. It's watching all the different numbers that the surgeon doesn't have the capability of monitoring, and helping you decide intraoperatively in live time what the safest best practice is. And again, that's the future. That's not today, but that is where we are all heading. We all want the same thing, right? We all want patients to get the best outcome by having the best decision-making we have.
Great. No, thank you for that. I will quickly answer the next question. Does the OR need to be using J&J laparoscopic disposable products, or can it be any product line? No, the short answer is no. So we've developed this technology to be hardware agnostic, to have broad procedure application, basically to work in any OR with any video capture device. And you don't need to be a J&J customer to use it.
I will also say we have it hooked to our endoscopy tower, so we're capturing endoscopy cases. Laparoscopic, it's a small little tablet that hangs on the side. You can walk around with it sometimes. It's not at all difficult.
So Dr. Joseph, I'd like to go back to this, the kind of this big topic that you opened up, which is that, the practice of surgery is heading in this direction. And by that, I mean in a direction where perhaps, routine video capture will become standard, could become part of the patient record. Routine video capture and video assessment could become required for reimbursement. That's a big vision, and that's a big future state. What do you think are the barriers to getting us to that future state? What needs to happen between where we are today, where we have some of the core technology now available, just starting to penetrate operating rooms, to then this future state where this becomes ubiquitous technology and standard of care for patient records and reimbursement?
So I think there's a couple steps, and I always look to the past and judge the future. It could all change, of course, but when you look at historically technologies like this or kind of disruptive innovation have started in the educational realm, right? The reason I started all of this by saying I'm a program director is that when I can assess residents in real time over and over and over again, and those residents train for 5 years to become a surgeon, and when they are done 5 years from now, they have a video library of their own showing them doing the cases and scoring in a nationalized standard, scoring metric. Step one is the hospital, and each of you that represents a hospital, your privileging and credentialing is a pain in the butt. And every one of you send me a letter asking me if this surgeon that is applying for privileges is safe, right? And I am not allowed to legally answer that question. My legal answer is that the resident, when they trained with me, did this many cases, and they were deemed competent enough to sit for the American Board of Surgery exam. That is the answer I must give, right? That doesn't help any administrator. It doesn't help the hospital system. It doesn't even help the surgeon applying for privileges. However, this is that bridge. This is the gap, right? This is that spot where the privileging credentialing folks can say, we have reviewed, or the American Board of Surgery or whomever can say, we've reviewed these videos and we know that this person was performing at a safe surgical space to do these procedures. And that is your step one, right? That's your first domino into driving the insurers and Medicare and everybody else into the space. Now, separate from that, you've got a lot of the ACOs and other people, the larger insurers that are privately funded companies that are now driving this as well and saying, hey, if we're going to private contract with a group to do orthopedics or bariatric surgery or primary care or whatever it is, we want to see quality metrics to prove that we are getting our value. And this is one of those steps that surgeons are taking to provide that quality metric. But this is the process, right? And it is moving along pretty rapidly. I can, in response to the question, the American Board of Surgery has convened an actual committee to look at specifically video-based mentoring and proctoring in the operating room, and they will make a statement probably in the coming year. That committee was just put together like less than a month ago is when it was announced. And obviously with COVID, it's a little bit slower, but this is where all of surgical education is heading, and wherever surgical education heads, often surgical quality and the insurer, the payer follows.
Great, thank you for those thoughts. Maybe we'll take a couple questions from the chat. So has any such data been required in any legal cases, such as if a patient were concerned about an outcome and alleged related to surgery? I can speak to that briefly, and feel free, Dr. Joseph. I personally am not aware of that. I will tell you that generally speaking, this entire use of data is done under a quality improvement and peer-to-peer learning umbrella, which means it's a sort of protected environment for surgeon information exchange and learning. I don't know, Dr. Joseph, if you have any experience in this.
Yeah, so two parts. Number one, no, I don't. No one has ever requested. But number two, because of the way it's done, it is virtually impossible to backtrack the video to the patient. So because everything is stripped from a HIPAA side when the video gets uploaded to CSATS, and again, I am no IT expert. Somebody smarter than me at J&J does that. That video is not even linked to a date. So the surgeon itself gets a report back, but it doesn't have a date, doesn't have a patient. It has a procedure, the surgeon, and a score. So because of that, it makes it very difficult to be discoverable on that side.
Right. And I can attest to that as well on the technology side. The videos are immediately de-identified, as you mentioned. I think this is somewhat related to the next question. Where is the data stored? Can the cloud server be selected by the user? Does the company control the data? So we have a very specific, high-trust certified cloud environment where we're managing this data that has to meet specific standards. The data is generally controlled by, of course, the patient and their hospital. We as a vendor or a service provider, gain access to that data for specific purposes, as authorized, by those data owners. So that's generally how the data flows and how we manage it. What does the American Board of Surgery think of utilizing this technology? I can tell you that it is certainly on their radar screen and under assessment. The scenario that Dr. Joseph described a few minutes ago with respect to this being part of training and sort of certification is very much on our radar screen of the ABS.
And I will add that probably highest priority for the ABS and myself as a program director is having a library for the graduating residents. So step one, the graduating residents that are starting surgical practice, having an ability to document their, safe practice in surgery becomes crucially important. And that's really where I would tell you that most of us in academic surgery are focused on, currently.
So we are near the conclusion of our session. Maybe I'll just pose one final question to you, Dr. Joseph, to close us out here. What advice would you have for all of the audience members here who are thinking about setting up a program like you have to, improve surgical quality, capture this data, enroll the various, stakeholders inside the hospital and demonstrate results? What are the steps that they should be thinking about taking to make this happen in their hospital?
Yeah, so you kind of hit a bunch of them. So I would tell you step one is bring your stakeholders together. And I generally say surgeons and then the OR staff. And I will use my own example. I am generally, and this is my own fault, I apologize, I should be a better person, but when an administrator comes and, tells me that they want to do something, I'm generally skeptical. On the other hand, if my surgical team, my tech, my nurse in my room come and say, hey, we heard about this really cool stuff and we want to look at this, you should look at it, I'm much more amenable and open. And again, I will meditate and work on being a better, more open-minded human being, but surgeons in general are very protective of their little cozy blanket. But step two is understand and really push home the concept that this is about improving quality and, most importantly, helping surgeons to get better. And more importantly, I often tell a lot of them, right, because the late adopters are the ones that tell me they're great. And I say, then absolutely do this, because if you can show me you're fantastic, I will personally call J&J and offer you up as an expert, right? Like, I will be happy to help you, And then obviously number three is getting everybody in the room. Generally, I find that a surgical champion is helpful. Obviously, I've served as the kind of surgical champion of my institution to talk to the other surgeons. They see me every day as the program director. They know my process, but getting those people and getting a champion that will really drive this forward are the really early steps. After that, once you have the CSATS machine, it becomes very easy. And I will tell you that my own nurses set it up and run it. They don't even wait for me or the resident to do any of it. If they know they're doing a gallbladder or something, and they know the resident's coming in, they are going to work on setting it up, get it going, and roll. So it becomes very worthwhile. And I will tell you the back end of that is gather that data, present it, show everyone that they're doing well. I will tell you, everyone thinks they're going to score poorly. They're very scared and nervous that they aren't doing that great of a job. And generally, surgeons are all high-performing individuals. And when they see that they're doing well, they get pretty proud of themselves.
Fantastic. Well, I think that concludes our time. I want to say thank you to our audience members. And with that, I will hand it over to our moderator.